Heavenly Father, bless us as we gather here together this afternoon. Bless our deliberations, unite us in our efforts, and guide us in our decisions as we strive to meet the needs of our patients. We ask these things in Christ's name. Amen.
Ask the secretary to please call the roll by sections.
The EACT section. Yes, please. EACT. Six. Nursing Service Administrator. 16. Thank you. General duty. 5. Thank you. Occupational health. Private duty, or public health,
Public health.
Public health I'm asking for now. Ten. Thank you. Private duty. 10. Thank you. Occupational health, anybody come in?
You have a reading of the minutes, please.
These are the minutes for the regular meeting, January 11th, 1968, which was held at St. Joseph's Infirmary at 4:30 p.m. The roll call showed the following present: EACT Section 5, Nursing Service Administrators 9, General Duty 3, Public Health 10, and Private Duty 7, establishing a quorum. The minutes of the previous meeting of November 9th were approved as read. In communication from the President, Mrs. Armstrong shared a resume of 3 meetings she had attended, which were the Private Duty Section, the Community Council of Greater Atlanta, and the Atlanta Board of Education and the Paramedical Group. There was no report from the Secretary. The order of business was reversed by consensus to allow time for the program to be presented. Mrs. Merle Lott, Program Chairman, introduced a panel of various medical and community council participants to the audience who would share with 5th District nurses information about better coordinated services for patients in the home. Represented on this panel were Ms. Loretta Roberts, who was moderator from the Greater Atlanta Community Health Council, Sister Mary Melanie, Administrator, St. Joseph's, Mrs. Marie Guston, Public Health Nurse, Mrs. Nora Wood, Visiting Nurse Association, Mrs. Lois Pagins, In-Hospital Coordinator, St. Joseph's Infirmary, Ms. Sandy Lou Overton, Director, Department of Nursing, St. Joseph's, Dr. Grady Clinkscale, Orthopedic Surgeon, and there's no summary of the program. But anyway, the report after this, then the report of the treasurer and secretary were given by Miss Carolyn Atkins. There was a resume of the meeting of the board of directors given. The action taken and recommendations of the board include a motion from the private duty section that, to the effect that A&A be asked to send a field representative to help set up levels of nursing for the private duty section. This motion was made by Mrs. Stedman and seconded by Mrs. English and was carried. This report was given to the membership by Mrs. Templeton, the secretary. The reports of standing committees, printing, given by Ms. Carolyn Atkins. Advisory committee to the registry, Ms. Overton. No other standing committee reports, no reports from special committees. The private duty section gave a verbal report, and there were no other, Mrs. Stedman gave a verbal report for the private duty section. There were no other section reports. There was no unfinished business. And under new business, a motion was made and carried. Mrs. Lott making it, Sister Melanie seconding it, that the 5th District Nurses Association approve a resolution subscribing to the National Memorandum of Understanding between the Veterans Administration and the ANA. Adjournment was at 6:15 p.m. Sarah Templeton, Secretary.
Are there additions or corrections to the minutes? Minutes stand approved as read. There's no objection. The order of business will be changed to allow our program committee to present its program. Is there objection? Hearing none, I would like to introduce to you again Mrs. Merle Lott, our second vice president, and chairman of the program committee. Thank you, Madam President. Fellow members of the 5th District. Program committee is very proud of the programs that we've been having. The only credit the program committee gets is that they cut the ad out of the paper, which was telling about a very wonderful program that Grady Hospital had put on at one of the national meetings. I did that when I found out I was a program chairman. And as luck would have it, one of the members of the program committee is Miss Tammy down at Grady. So it is to her, really, and to her staff that we owe this meeting. She wants me to say to you that her staff has done work, and for that reason she wouldn't come up here and introduce it. But once she's had me to introduce to you now, this is Laura Shaw who will introduce me, Ms. Shaw. I hope all of you have received a copy of the program inside one of our medical intensive care brochures. I wasn't trying to do any commercial advertising here, but I did want to put our program inside one of our very famous projects. It is a treat to be able to be here this evening to put this program on, and it was a delightful experience for myself and I'm sure Dr. Silverman and Dr. Fletcher to be able to go to San Francisco to the American Heart Association Clinical Nursing Conference and participate in their program and give you hopefully the same type of program that we get that Saturday evening. This evening we want to talk to you for a few minutes about a possession which we all have. Something which is more valuable to us than anything else, life. More specifically, we want to talk to you about the saving of life. In the words of Dr. Claude S. Beck, Many cases of cardiac arrest involve hearts too good to die. Often the heart only needs a second chance to beat. Mouth-to-mouth breathing was practiced in biblical times, and throughout the centuries some reference has been made to attempts by physicians regarding various methods they employ to restore the heartbeat. Early in the present century, internal cardiac resuscitation began to be practiced. However, this procedure failed to gain clinical acceptance even after many experimental studies. The present procedures of mouth-to-mouth breathing and external cardiac compression were introduced early in 1960. It can be initiated without any equipment and used anywhere in the home, in the office, in the hospital, or even on the street. The simplicity of training persons in this technique is a decided advantage. It's true that the nurse's responsibilities before, during, and after a sudden cardiopulmonary arrest are complex. If an emergency occurs on the street, the nurse has the same obligation as any other private citizen to render whatever first aid the situation demands. In the hospital, emergency situations occur in which the nurse does not have time to wait for a physician's orders. She must therefore be prepared to resuscitate and to carry out necessary therapy. We all use the term properly trained, and I have already indicated that the simplicity of training persons in this technique is a decided advantage. However, proficiency in cardiopulmonary resuscitation demands planning and practice. Each institution must determine what training is proper and necessary to safeguard patients' lives. All hospital personnel must organize themselves to learn how, as a team, they can best care for the patient. Continuing education for all hospital personnel will be a way of life in the future. I would like to now introduce to you Dr. Gerald Fletcher, who is Chief Resident in Medicine at Grady Memorial Hospital. He is a graduate of Emory University School of Medicine, Atlanta, Georgia. He is married and has 2 children, and he has been most helpful in assisting the nurses in their program. Dr. Fletcher will discuss the general approach and management of cardiac arrest.
Long trip in the back. Thank you very much, Samuel. Michelle, do we have a point? That's okay. We don't, that doesn't matter. Also, I'd like to give you just 2 or 3 different aspects of cardiopulmonary resuscitation. Now, first of all, I'd like to discuss the approach to cardiopulmonary arrest. After this, he will follow me and discuss some of the problems with cardiopulmonary resuscitation, cardiopulmonary arrest, and how to cope with some of these problems. Mine will be very general, and let me say at the outset that we are dealing with something that affects the circulation and the respiratory system of the body. You know, in the cardiac arrest, we reflexively sort of say cardiac, but in the last year or so, we're trying to get to the habit of saying cardiopulmonary arrest, because this is really what the problem is. The circulation is defective, the lungs will be defective, vice versa. So we must think of these things together. Now, there are 2 or 3 things we have to consider initially is how do you recognize a cardiac arrest or a cardiopulmonary arrest? And for the purposes of this session, we will consider a cardiopulmonary arrest as occurring within a coronary care unit or within an intensive care unit. Cardiac arrests occur everywhere, but let's consider, just for the purposes of this discussion, within the coronary care unit. And there are a number of ways we can recognize this. Mark, that's the first slide. The recognition of cardiopulmonary arrest, CP just is the abbreviation for cardiopulmonary. We, first of all, have a monitor. Now, most in coronary care units, of course, have monitors at least on part of the patients, or if not all of them. This can be very helpful, and sometimes is overly helpful in that we rely too much on it. But the visual observation of a monitor in a coronary care unit can give us some time indication of the cardiac electrical activity, whether or not it's present, what it is if it's present, and what the patient is doing electrically. Of course, with most coronary care units, either the tachyarrhythmias, fast heart rates, or the slow heart rates are set such that they will triple alarms, very simple as most of you are familiar. So actually the monitoring of the patient itself. If the monitor is not working, or if for some reason the monitor does not pick up the electrical problems that occur in a patient, which frequently does develop without changes in the electrical activity, the patient might react in the form of a seizure, tonic-clonic epileptiform type of convulsion, which is the manifestation usually of a decreased cardiac output, cardiac standstill, ventricular fibrillation, or some other arrhythmia. Frequently, an arrhythmia would present as a seizure. Thirdly, of course, very obviously, absence of blood pressure. Fourthly, very obviously, absence of a pulse. And we must keep in mind that electrical activity, as depicted by a monitor, may not really truly typify what's going on with the patient. So let me emphasize here that if you see at your console for the nurse at the nursing station or at the bedside monitor some activity that looks normal to you, don't always rely on this. If something looks funny, if the patient doesn't look right, going to the bedside by feeling of the patient's pulse, checking his blood pressure, frequently will give us clues to the recognition or the insidious onset of a cardiopulmonary arrest. So monitoring is good, but monitoring is not the entire answer. Last of all, respiratory cessation, of course, is another vital parameter that should be considered, and that is frequently a way cardiopulmonary arrest will develop. So keeping these things in mind, I think this will give us an idea of how we diagnose the cardiopulmonary arrest. Now, let's have the next slide, Mark. We like to use a little mnemonic, I guess you might say, or a little way to think about cardiopulmonary resuscitation. And Dr. Steinhaus corrected me the other day. I said we just cardiopulmonary arrest because everything must be done immediately, so we just act reflexively. Dr. Steinhaus corrected me, said we must think and act reflexively. So I'll just pass on to you as he told me. I think we must think and act reflexively at the same time. But many times this is often just reflex medicine, so to speak. There are certain things you do when cardiopulmonary arrest is diagnosed that oftentimes, I can recall specifically, and so many of you have, that you don't have time to really think, you just act. Of course, you hope you're thinking, knowing what's going on while you're doing this. But it's very important to be able to react without hesitation. The old adage that 6 to 8 minutes can bypass without difficulty with the patient or without brain damage, without vital organ damage is really not a true thing. We must act promptly. 1 to 2 or 3 minutes sometimes are called permanent damage, either temporary damage or immediate damage, or permanent damage that is manifested later on in the patient, 6 or 8 weeks later, whereas poor oxygenation to the brain may have effects of that type. So act promptly. The 6 M's I put up here, you just look down the list, each one of these letters starts with M. And I think this is just for me, in a very simple way, a way to think of cardiopulmonary arrest, or you might just use 5 M's, using the last 2 as machinery. Now the manual thing, first of all, is just to go through these briefly, then a little more detail. Manual means a blow to the chest, which I'll describe. Manipulation means putting the patient in the proper position, and this at the same time means ventilation. Many times patients will ventilate themselves properly if they are put in the proper position. Cardiac massage, which I'll emphasize more, medications, monitoring, and machinery in the form of a defibrillator. Let's see, Mark, let's see the next slide now. I think we'll go into a little more detail about this. Now, frequently, we have had experience in the last year or so that a cardiac arrest is diagnosed, and the first thing we do is hit the patient on the chest. Now, this is a very true, heavy, brisk blow to the base of the sternum. It should be done not more than 1 or 2 times. The base of the hand hitting the chest very rigidly, and done at, like I say, the lower sternal angle. For some reason, physiologically I can't explain, it will at times shock the heart, if you want to call it that. The jolt will initiate electrical activity within the patient who is at the cardiac arrest. For example, here, we documented this one time definitely. It has been documented a number of times by the patient responding promptly, but we did have an EKG going in one patient last year, and the patient was in ventricular fibrillation or flutter, a very ineffective cardiac rhythm that had no electrical activity of any importance. There were no pulses, no blood pressure, and for all practical purposes, essentially dead. The patient was struck on the chest, as I described, the base of the sternum, very briskly, and after the manual blow on the chest, at a normal sinus rhythm, P wave, QRS, T wave. This was authenticated, and we know it occurs. Maybe 1 time in 500, but still it's worth 1 blow on the chest. First thing in the approach to cardiac arrest, a manual blow to the chest. Don't waste more than 10 seconds. Maybe 1 good blow or 2 good blows. And after that, the initiation of cardiac massage, external massage. Now, external massage is, the purpose of, is to propel blood from this static heart so that the blood will perfuse the vital organs. Vital organs mainly being the brain, the initial part, and later on, possibly, if the resuscitation is carried through a number of minutes and hours, to perfuse the kidneys and other vital organs. Cardiac massage should be done by using the base of the hand, if you're left-handed or right-handed, making some difference. Now, if you're right-handed, the base of the left hand should be placed at the base of the sternum, so as you can give active pressure with your dexterous hand, or the hand that you use normally when riding, playing baseball, etc. So, the base of the sternum, using this just as a guide, but the pressure with the hand that you're accustomed to using pressure. It should be done in such a position that, you can refer back, Mark, to that first slide, the one right before this on again. And manipulation, I think, comes into this time because the patient, before external massage is begun, should be in a proper position. That's right. Manipulating the patient. If the patient falls out of the bed on the floor, cardiac arrest, putting him promptly on his back, his head in the extended position for proper ventilation, which I'll refer to in just a minute, and beginning the external massage. Slightly attempting to propel the blood towards the head, not pressing down on the patient so as to propel blood downward, but massaging in a cephalad or a headward position so as to hope to propel the blood forward. The pericardium is a sac that goes around the heart. We hope and think that the heart within the confines of this sac, with the pressure, will help push blood from all sides and propel the muscular part of the heart to propel blood out. So, now let's have that next slide, Mark. That's it. At the same time with manipulation, we must remember ventilation. And this is of essence. Many times a cardiac arrest will occur, the patient will be breathing normal. So some of the mistakes we make at times are trying to ventilate a patient with very confusing and complicated methods, using endotracheal tubes, laryngoscopes, and maybe attempting to do a tracheostomy initially, which is not necessary many times. Normally, if you'll notice here, the problem involved is the tongue. I can't quite reach that high, but the tongue is the main problem. And frequently a patient, when they collapse in bed or have a cardiac arrest in bed, they will be in such a position here, where the tongue is, over here, where the tongue is blocking the air passage. So very simply, if you can see how positioning the neck, which we'll see in the next slide, would attempt to open this air passage, there would be no problem. So let's see the next slide. So very simply, by tilting the head, one can open the air passage very easily at times and not have to have difficulty with trying to pass the laryngoscope or other methods of ventilation. Patients with cardiac arrest, any coronary kidney problem is usually with the heart. So if you can just give them the proper position, they'll ventilate themselves. very simple, like I say, in many instances. Of course, there are complications. But using the simple approach, manipulation of the patient, head, his angle of his mandible anteriorly, head tilted back slightly, and just let him breathe. You have his heart going, you hope, a cardiac massage. Just let him breathe on his own. He will do it frequently. Okay, let's see now. The next step I think we should emphasize is what medications should we use? Let's turn the slide up just a bit more. Medications, I think, at times are used in a rather redundant manner. In other words, too many medications are used. We've come down to the minimum, or at least the maximum, of using two medications: sodium bicarbonate and epinephrine. It's well documented, and a great deal of work has been done on this, something recently reported in the New England Journal, which might be of interest to some of you, about the metabolic acidosis that occurs after cardiopulmonary arrest. This doesn't occur hours after. This occurs immediately. Frequently, as soon as the heart stops beating effectively and the lungs stop respiring effectively, there will be a development of acidosis. And the problem with this is that the acidosis prevents the heart and the lungs from acting properly, prevents the myocardium, if it is stimulated, from responding properly and beginning to beat in an effective rhythm again. So the problem we're dealing with is acidosis. So reflexly, actingly, and thinking reflexly, we give sodium bicarbonate. Hopefully, in an acute myocardial infarction, an intravenous drip will be going. In our unit, most of our patients do have intravenous infusions going, and we can rapidly infuse 1 or 2 ampules, probably 2 ampules of sodium bicarbonate, 44 milliequivalents per amp initially, as soon as the diagnosis of cardiac arrest is made. The nurses, of course, are the ones who have it ready for us and infuse it for us or with us whenever this does occur. So infusion of sodium bicarbonate. Perhaps after that, if there's no response from the patient, that is, if he doesn't appear to be having an effective heartbeat, either by palpation or by other obvious signs, we can give epinephrine, usually 5 to 6 to 7 cc's of a 1 to 10,000 solution intravenous first. If it does not work intravenously, that is, if there's no response by palpable pulse, we can give it intracardiacally. I won't go into the details of this, but this can be done multiple times. And you realize I haven't mentioned a monitor, an EKG. We don't worry about that initially. If we can get these things done, we worry about the machinery later on. Too often, many times, people run around looking for the EKG machine. Hopefully in the unit, the monitor will be effective, but most, at least in our unit, most of our monitors, electrodes are attached to the chest. After the patient has his arrest, perhaps has had a lot of activity of his arms and hands, and perhaps with the massage we have disrupted the electrode leads, and I'd say 75% of the time we cannot get a recording from the monitor. So we don't have an electrical recording. But we don't worry about this initially because we know that what we're doing is effective. We hope that somebody, a third party, will come along that can get the EKG machine for us. So let's see the next slide, Mark, where we are. Here's an example, just to drift back 1 minute, of a patient who had external massage. After some sodium bicarbonate and epinephrine, he had a straight line EKG here, probably a ventricular standstill, or perhaps a very fine fibrillation. Here with external massage and some medications, he had the movements with external massage and then began to have a normal induction. He wave, QRS, he wave, QRS. So with external massage, proper ventilation, proper sodium bicarbonate infusion, and I believe this patient received epinephrine. Those things, just with external massage, by the time we got the EKG machine going, he was having this rhythm. And we're not sure that he may have had this initially just with the first pump on the chest, so to speak. So we don't worry about when it happens. We know what to do without the monitor, without the machinery. Let's see the next slide, Mark. Now, another thing we might mention that we've been using recently to assist us somewhat in external massage is a cardiac press. You have a cardiac arrest here. This is something that has been somewhat helpful to us, we believe. Those of you who have been in a cardiopulmonary resuscitation realize that this is work. And cardiac massage, external massage, is nothing easy. And for the most robust of our interns and residents, they tend to give out easily. And this is something that we find is a problem in a prolonged rest for 5 to 10 minutes. So the cardiac press is a mechanical device. Simply to place a very soft rubber structure on the base of the sternum where the hand should be, and a lever fulcrum type mechanism where this is pressed down by the intern, resident, or physician available rhythmically with 60 times per minute, stopping every 5 or 6 times for ventilation, and simulates external massage. We've checked a few patients' cardiac outputs and found this is not quite as effective in provoking a good cardiac output as is external massage of the hand. But it is good. It's good enough, and with a long resuscitation, patient with multiple arrhythmias who has to be massaged periodically, this has been very helpful, very helpful. Let's see the next slide, Mark. Now, last of all but not least is, as we come down to the machinery. First, we've had the manual blow on the chest. Secondly, the manipulation and ventilation at the same time. Thirdly, the external massage. Fourthly, medications, bicarbonate and epinephrine among other medications I think Dr. Silverman might mention later on. But in the immediate period, the next thing we need to do is consider using the defibrillator. Here, Dr. Silverman here is beautifully depicted by the bedside in a simulated cardiac resuscitation. The surgeon was very kind enough to let us use her for purposes of showing exactly how the paddle should be placed. Now, we must make note that the patient's head is not in the proper position. I think one purpose of this slide is to point out this is not the proper position for ventilation. The patient's head's on a pillow. This is one thing you should just throw away this time. The pillow should be out of the way. The patient is just, for this purpose of this slide, showing us where to put the paddle. This is the defibrillator, which I don't think we'll go into detail with, but only to comment that we have had a number of cases that have had defibrillation or cardioversion in expectation that the patient was fibrillating and has converted to a normal rhythm. Let me say that we didn't know whether these patients were in ventricular standstill, ventricular fibrillation, or an ideonodal rhythm. But it is well known and well documented that a few shocks from a defibrillator like this is much less harmful to the heart than is a few seconds or perhaps a minute of cardiac arrest. So we are beginning to cardiovert or defibrillate a lot of patients, not knowing the rhythm, but knowing it's an ineffective rhythm, knowing they have a cardiopulmonary arrest, either ventricular fibrillation or ventricular standstill. Here is a cardiac monitor, which if this were a resuscitation, we would have gotten to the bedside, but not the first thing to worry about. We have the combination here of the oscilloscope, direct right-out recorder with EKG, and the defibrillator, all in one package. These machinery items are not the most important thing. All right, have another slide. Now here is a patient who had cardioversion here. We do have a graphic recording here of ventricular fibrillation. He was shocked with 300 watt seconds, and you can see the ventricular fibrillation here, and the sinus or a nodal rhythm probably after, but a very effective rhythm that was palpated by feeling the radio pulse. Next slide, Mark. And just another example of a patient over upper left, and a sinus rhythm probably, or an effective nodal rhythm going into ventricular fibrillation flutter. A good little strip of it, right on down over here where you can see by the label he received another 300 watt seconds and converted to a nodal rhythm or an effective palpable supraventricular rhythm. That all the slide. Last of all, yes, okay, now we've been through this approach. Remember this approach, we've talked about it for a little while, but it takes more than, it should take no more than 1, 2 to 3 minutes. And We think reflexively and act reflexively. And the effectiveness of our resuscitation can be measured by a number of things. These are not real good usually. Just parameters that we think about when we are looking at the patient to see if he's been adequately or successfully resuscitated. And these things, pupils, pulses, skin color, whether or not he's breathing, and some type of movement of his arms or legs. So observing the patient, sometimes the pupils are very misleading, and resuscitations have gone past 20 or 30 minutes, they're not reliable. Pulses, of course, very obvious, and the other things a little more obvious, a little more helpful at times than pupils. Pupils early at times, if they are constricted or are still reactive to light, they are helpful. But sometimes patients can die with constricted pupils as well as dilated pupils. So this is not absolutely of diagnostic accuracy. Side of the bar, just in summary, let's remember that the approach to the cardiopulmonary arrest involves ventilation as well as circulation. And this must be done not in 6 to 8 minutes as has been described in the past, but immediately, done reflexively and with the sequence that we describe here. And hopefully with this, in many cases of our patients with hearts too good to die, like Ms. George told us, we will have success. And in the approach we have used, we've had good results at our hospital, and I anticipate more in the future. Thank you very much.
Now I know why we're so proud of our young men that help us out in nursing and Grady Hospital. Dr. Mark Silverman will now tell us why be concerned about arrhythmia. Dr. Silverman is a fellow in medicine, cardiology, Emory University School of Medicine. He received his MD from the University of Chicago School of Medicine, and for the benefit of all the young ladies in the audience, he is a bachelor.
Feeling I'm on an auction block and I should show my teeth so you can check them out. How strong they are. But as a matter of fact, Mr. Shaw has given me a good lead-in because I'm sure as you look at me, someone in this room is probably having an arrhythmia. It may be a very simple one. It may just be an atrial contraction. It may be a ventricular contraction. It could be a short burst, I should hope, of atrial tachycardia or ventricular tachycardia. And yet no one, particularly myself, is rushing to your side at the moment with an electrocardiographic machine. No one's dripping bicarbonate ominously from a syringe. No one's yelling, where's that nurse? Or let's get some help in here. And there's for a very important reason, because in this room, in this setting, supposedly, almost everyone here has normal hearts or relatively normal hearts, and therefore these routine electrical disturbances, this occasional ectopic atrioventricular beat, is not of great importance. However, that very same atrial beat or single ventricular beat may be of ominous consequences in the proper setting, that is, on the coronary care unit in a seriously sick patient whose heart is suffering the consequences of an acute myocardial infarction or is belabored under the disabilities of an electrolyte disturbance or pulmonary embolus. That very same rhythm disturbance may initiate a very serious rhythm problem, namely ventricular tachycardia, ventricular fibrillation, or cardiac standstill. So today I would like to look with you at some of the differences in that person in the coronary care unit and in that person here, and determine why it is that the arrhythmia causes that person a great problem, and when it is that we should treat rhythm disturbances. Now, the first slide, Jerry, and also for the rest of them, shows some of the reasons why we're so concerned about arrhythmias. This is a slide we used in California showing that in 1957, as contrasted with 1967, there's been a major change in the deaths due to arrhythmias. deaths early in 1957 due to arrhythmias, 15 or so, and here 1 to 2. And why is this? Well, it's because now we can see the arrhythmias as they're occurring, and we can treat them quickly. We can recognize them, and we can institute therapy before dangerous consequences can occur. Now, this is extremely important because we didn't previously have coronary care units. Now, coronary care units have developed in the last few years only, and they've been so sometimes to the exclusion of the realization as to what we can do with them. We have a lot of very pretty equipment, but sometimes we don't appreciate what the equipment is for, or we don't have the properly educated nurse or physician to use the machinery properly. As a matter of fact, I was just out in California last week, and one of the discussers out there was talking about coronary care units, and he said that coronary care units have become so much a part of the pride of the local community that he fully expects to go through a town and see a billboard saying, be sure to see our new coronary care unit, turn left at the next exit. And to some degree this is true. May I see the next slide? So, a great deal of deaths occur due to arrhythmias, maybe 15 out of this 100 cases. And though deaths occur to arrhythmias, it must be realized that maybe 90 to 100% of patients who are carefully monitored on an intensive care unit are having arrhythmias. Well, we don't treat 90 or 100%. We have to use some judgment as to who to treat and why to treat and when to treat. And we do so with several things in mind. The first one is that not every patient requires therapy. There are many patients that can be observed carefully in the coronary care units. Their arrhythmias can be noted, but we don't rush in with drugs that have their own dangerous side effects, drugs that can cause deterioration of the patient's clinical state in and of themselves. We don't give them superimposed medical complications. But when the arrhythmias have hemodynamic effects on that patient, or when they predispose to electrical consequences, then we must rush in to treat the arrhythmia as effectively and as quickly as possible. Let's examine these in turn. May I have the next slide? First of all, the effects, how can the nurse herself recognize that important hemodynamic effects or electrical effects are occurring? Now, we're excluding from this cardiac standstill or cardiac arrest that Dr. Fletcher has so well discussed. That's obvious. In this case, however, we're talking about rhythm disturbances, atrial tachycardia, ventricular tachycardia, sometimes just ectopic ventricular atrial contractions. And these alone, in the proper setting, in a patient with severe heart trouble, may produce shock. All of you are aware of the clinical signs of shock, such as sweating and tachycardia, pallor, anxiety, such as congestive heart failure, shortness of breath, again, apprehension, anxiety, angina pectoris, chest pain, or cerebral ischemia, confusion, a very common sign of an arrhythmia in a severely damaged heart. Next slide. Now, what determines whether the rhythm disturbances produce these important changes, that is, shock, congestive heart failure, angina pectoris, or cerebral ischemia? Well, some of the following I've listed here. Number one is rapidity of heart rate. Many patients can tolerate any kind of arrhythmia as long as it's not too fast. If it's 80 to 100 to 110, that's fine. But when the heart goes faster than that, 130, 150, sometimes 180 or 200, then this produces serious problems, which we'll look at a little bit later. The duration of the rapid heart rate. Many of us, people with a myocardial infarction, can tolerate a heart rate of 150 or 180 for a few minutes or up to a half an hour. As a matter of fact, there have been patients that have been described who have apparently normal hearts who have gone into atrial tachycardia that have been present for 7 or 8 years. Ventricular tachycardia continually has been present in certain people for 7 or 8 months without any therapy whatsoever, without any symptoms whatsoever. But these patients must be contrasted with our seriously ill patient on the coronary care unit who cannot tolerate that same rate, 110, 120, or sometimes even the rate of 100 or 90. That's too fast for them. Finally, as you're all aware of, the age of the patient determines to a great extent what other superimposed problems may be. It may not be the heart that needs to be focused on, as we're so often aware of in the coronary care unit. It may be that the heart symptoms are associated with other symptoms. Atherosclerosis of the vessels leading to the brain or going to the kidney. This rapid rhythm may decrease the blood flow to the brain or to the kidney, producing lack of urinary output, or cerebral ischemia, or a cerebral vascular accident and a stroke. So, even though we're commonly concerned with the heart in the coronary care unit, always remember that as cardiologists, as cardiac nurses, we have to be concerned with the entire patient. We also have to look for the effects of this cardiac rate on other organs. Next slide. As I've stated, the presence or absence of atherosclerosis involving the other vital organs which need that blood supply coming from the heart. The effects on blood pressure. This varies a great deal. As you know, many patients are comfortable at a blood pressure of 80/60, for example. Some are uncomfortable at a blood pressure of 120/80. So the effects on the blood pressure in that specific patient are very important. It may be that even a pressure of 120/80 is not enough. We have to give a drug to elevate that pressure or to reduce the arrhythmia so that we can try to raise the blood pressure a bit. Sometimes that pressure is too much. Sometimes we have to decrease the blood pressure by treating the rhythm disturbance. Next slide. Now, let's focus a little more attention on the underlying physiology of rhythm disturbances. That is, what is it that a tachycardia does to the heart to produce these other consequences, these deleterious effects of angina, congestive heart failure, syncope, cerebral ischemia. Number one, with tachycardia, diastole is shortened. Now, as you're all aware of, the cardiac cycle is divided into systole and diastole. Systole is relatively unchanged when the heart rate gets faster. Diastole is what's changed. Diastole is very important because during diastole, the ventricles fill from the atrium. The ventricles are dependent on the length of that period to get all the blood from the atrium. If we shorten diastole, less blood can get into the ventricle, and therefore less blood is available for the next cardiac output. The decreased cardiac output leads to decreased blood supply to the extremities, to the kidney, to the brain. It also leads to decreased blood supply to the very vital coronary arteries. Next, the atrium play a very important part in cardiac output. In many rhythm disturbances, particularly atrial fibrillation or atrioventricular dissociation or ventricular tachycardia, the very important sequence of atrial contraction just prior to ventricular contraction is lost. When the atrium contracts just prior to ventricular contraction, they do several important things. Number one, they contribute a very important increment to the ventricular volume for the next cardiac output. Number two, they help to close the mitral valve. If the mitral valve is not closed, then blood can regurgitate back into the left atrium during ventricular systole and not go out into the aorta where it properly belongs. Number three, decreased coronary blood flow. Now, I've already implied that with diastole, blood flow, with a shortening of diastole, we have decreased cardiac output. With decreased cardiac output, decreased blood supply to the coronary arteries, decreased coronary blood flow. But in addition, a very important point, and one that we don't think of very often, that is that blood flow occurs to the left ventricular myocardium only during diastole. During systole, the pressure of left ventricular contraction is so intense that it clamps down on those coronary arteries and does not permit blood to flow through them. So the left ventricular wall is entirely dependent on the length of diastole for its blood supply. If we shorten diastole, we not only decrease the amount of blood going to the coronary arteries, but we decrease the amount of time the blood can flow through them into the left ventricle, bringing needed nutrients and oxygen to that belabored left ventricular myocardium. The ventricle also must recover during diastole. It cannot store up oxygen, it cannot store up energy supplies during systole. It uses them all up during each systole. It can't store them for the next 3 cycles away. It's entirely dependent on diastole to replenish its entire oxygen supply and its energies. Again, shortening of diastole, decreasing oxygen supply and energy to the left ventricular myocardium. And finally here, asynchronous ventricular contraction. Normally the ventricles are stimulated from the apex to the base, so they contract, forcing blood upwards. The base is stimulated first by a rhythm disturbance beginning in an abnormal location, and the base may contract against the apex, decreasing the amount of cardiac output. The implications of this are not completely understood. So let me show you again the vicious cycle that's happened. We've shortened diastole, and by shortened diastole, we've decreased the amount of cardiac output, decreasing the amount of blood supply to the brain and the kidneys. By doing this, we've also decreased the amount of blood to the coronary arteries, decreased the amount of blood flowing to the left ventricle during diastole. But in addition, we have caused the ventricle to work harder. The ventricle contracts faster and uses more oxygen. We're not giving it that oxygen. We're not giving it that needed blood supply to replenish its stores, to give it time to rest in preparation for the next ventricular contraction. Eventually, the ventricle becomes inefficient and fails, and when it becomes inefficient and fails, then it's predisposed to serious electrical consequences. Next slide. Which I have listed here. When the ventricle becomes anoxic, when it's working more than it usually does, in the setting of a myocardial infarction, where we have damaged ventricular tissue, then we get increased ventricular irritability, ectopic ventricular contractions that may lead to ventricular fibrillation or ventricular standstill, the very thing that we're trying to prevent. Next slide. Isn't that last slide?
That's all.
Okay. Well, I tried to pose for you in a very short time in a quite rapid manner the effects that arrhythmias can have on the heart. And I've tried to do this by pointing out to you that in many cases, these arrhythmias have no effects on the heart. In this room, when no one is suffering from an acute myocardial infarction or a pulmonary embolus, the effects of this arrhythmia are of no consequence or of very little consequence. But that very same rhythm disturbance in a very different patient may produce deleterious, critical, emergent consequences in the coronary care unit. Now, it's in this very same rhythm disturbance may be treated differently by the same physician in that same patient at a very different time. It's the clinical setting, where it occurs and what time it occurs and what it's doing to the patient that must be taken into consideration. And it's the educated nurse and the educated physician who are aware of the consequences of these arrhythmias and who know when to treat them, who can best bring about a safe reaction, a safe a heart without electrical consequences such as ventricular fibrillation and ventricular standstill. Thank you.
Thank you, Dr. Silverman. Sister told me, she said, I bet you're embarrassed, Dr. Silverman. I said, no, knowing him, I don't think I did. Mrs. Vicki Bischoff will now discuss the nurse's role in cardiopulmonary arrest. Mrs. Bischoff is a graduate of Barron Salama Hospital in Chattanooga, Tennessee. She is employed at Brady Memorial Hospital as a very able assistant coordinator in service education nursing service. Ms. Bischoff.
I thought I had secured someone to operate the slide projector, but he got up and left. So if I got any volunteer, I think I'd like to speak about what does the nurse do when she is confronted with a cardiac arrest and there is no doctor present. Could you show the first slide, please? The only alternative to diagnosing the situation and initiating immediate therapy is simply to call the physician and wait. Next slide, please. This alone may result frequently in action which is often too little and too late. Next slide, please. Success depends.
Wait a minute.
On many factors. Whether the nurse should start resuscitation is decided by the policies and procedures of individual institutions. It is the general belief that if all of the signs of cardiac arrest are present, it is proper to assume that cardiac arrest has occurred. Neither blood pressure measurement, EKGs, or any further studies are necessary prior to institution of therapy. Someone other than the nurse trained in resuscitation therapy should call a doctor or cardiac arrest team. She could be expected to apply closed chest cardiac resuscitation as an emergency measure. The time that the cardiac arrest was diagnosed should be noted. Then, a sharp blow or two should be delivered over the pericardium. This blow is often sufficient to cause cardiac activity to resume. If this is ineffective while waiting for assistance and equipment to arrive, she will continue with resuscitative efforts. Next slide, please. That's supposed to represent the maintenance of circulation, but that's okay. The properly trained resuscitator should be aware that oxygenation of the patient is vital. The first consideration should be given to opening the airway adequately by hyperextension of the neck, removal of any foreign material, and the preventing of escape of air by occluding the nostrils and sealing the mouth. When no other equipment is available, the nurse should begin mouth-to-mouth resuscitation immediately. After inflating the lungs rapidly 3 to 5 times, check for carotid pulse. If this is present, continue 12 lung inflations per minute. Next slide, please. If the pulse is absent and the pupils are dilated, the nurse would locate the correct pressure point, which is the lower half of the sternum, and position herself to the side of the patient, who should be on a solid, flat surface. Pressure should be applied with the heel of the hand, and the sternum depressed 1 1/2 to 2 inches toward the spine at the rate of once per second. If she is still the only person available, she would alternate 2 quick inflations and 15 compressions until assistance arrives or a spontaneous pulse returns. If she is the only trained person available, she must be prepared to administer additional therapy, such as defibrillation, as necessary in accordance with her abilities and in compliance with her hospital's governing policies. Next slide, please. When the physician is present or arrives, he will probably do the cardiac compression. He may ask the nurse to apply artificial respiration or assist with the maintenance of patent air passages. Next slide, please. Of almost equal importance to prolonged effective resuscitation is the availability of equipment, drugs, and personnel to assist the operator. Dangerous delays can occur if personnel must gather equipment from many different sources. The maintenance of an emergency cart such as this on each area with the following equipment is desired. Next slide. An S-tube or face masking bag, a laryngoscope with endotracheal tubes, though prolonged attempts at endotracheal intubation should be avoided, a tracheostomy tray, next slide, drugs which may be needed to be kept on the emergency cart, equipment for a cut down, next slide. If the patient does not have an intravenous infusion running at the time of the arrest, will most certainly be needed. Next slide. That's good enough. Other equipment to be readily available include the ECG machine. Next slide. Electrojelly, defibrillator, and if possible, an oscilloscope. It may also be the responsibility of the nurse to aid the physician to check the effectiveness of the compression, palpation for pulsation in the parietal, brachial, or femoral arteries. Next slide. Measurement of systolic blood pressure, observation of skin color, and observation of pupillary reaction are essential. Next slide. The electrocardiogram is a more efficient monitoring tool and should be among the first equipment brought to the patient. The nurse should know how to attach and run it. If possible, it is placed so that the physician can see the strips or view the oscilloscope. Next slide. Next slide. The defibrillator stimulates the heart by delivering an electric counter shock to restore a sinus rhythm in fibrillation or standstill. Whether to use it or not is usually the decision of the physician who is in charge of resuscitation. The nurse can be of assistance, next slide, by seeing that an adequate amount of electrojelly is available since severe skin burn may occur if this is omitted. The nurse should also see that no one is touching the patient when the shock is delivered. The ECG machine should be disconnected when the defibrillator is in use. If it is not, the electric impulse may burn the ECG unit out. Another essential role of the nurse, which is sometimes overlooked in the excitement and drama of the situation, is that of a reporter. Information on the time lapse between the first appearance of arrest symptoms and the initiation of resuscitation may have some bearing on the course the doctor will follow. Next slide, please. The amount and timing of drugs being administered is valuable information to be recorded. Periodic checks on the rate of compression being maintained and perhaps relief of the doctor for a few minutes to rest or to do a cut down or insert an endotracheal tube makes a valuable contribution. Next slide, please. The patient who has been successfully resuscitated must be closely watched in the post-rest period. Blood pressure, pulse, rate and rhythm, respiration should all be monitored frequently, probably every 15 minutes in the first few hours after the arrest. Special monitoring devices such as the oscilloscope may be helpful to the nurse in measuring the rate and rhythm of the pulse. Changes in these functions may be distress signals and warn of another arrest. Blood pressure cuffs may be left in place but should be reapplied frequently. Next slide. Keeping tracheostomy tubes and air passages clear of secretions is also vital. The patient's temperature should also be taken frequently for signs of damage to the temperature controlling center of the brain. Sudden rises in temperature may indicate another crisis. Convulsions and other symptoms of CNS damage may occur, adding to the stress on the patient. Observing the kidney function in the post-arrest period is also important.
I think that any communication to Mr. McClellan that was not sent through the proper channels should have been ignored by Mr. McClellan and accepted by him as personal mail. And I do not think that you want any obligations to publish anything that did come to you. It did come to her. Apparently not. That commission pending in September, I am just asking a question. Why do we need another parliamentarian if we're not going to have a, before September, if we're not having a meeting before September? Yeah, that's what be some money spent for nothing, really, because we'll have a meeting until then. But we don't need one at that. Not right now. May I make one statement now? I'm not entering in this. What I'm stating here is a fact. Before Mr. Jackson died, he was called for many, many meetings at various and odd times. And it was understood and relayed to Mr. Jackson, also to us, that no one should contact him unless it came through the 5th District headquarters. Now, Elizabeth knows that to be a fact, that nothing to the legal counsel is official unless it comes through the 5th District headquarters. So we did not have it. We did not know it. And I'm sure that we would publish it in the meter if we had. Now, on the book, I gave Mr. McClellan. Now, I'm not in the argument one way or the other. I'm just giving you a fact. We put on the agenda a part parliamentarian. On there. The word council was used because it sounded better. At the bottom of the page on this book, we got off all of Mr. Jackson's rulings, so the new parliamentarian would have it so anybody who wanted to come in there could see all the rulings. And underneath there, Ms. Dixon has stated this definitely, and it was printed in the meter. Mr. Jackson, 5th District Parliamentarian, legal advisor to GSNA. So when that was given to Mr. McClellan, he referred to it, then he realized that that was what he was employed for. Mr. Jackson and Mr. Chalmers were employed purely as parliamentarians. We had no use for any legal counsel back in those years. In fact, we've had no use for any legal counsel until the past 2 years or the past year. I've never known that the 5th District ever go in for legal counsel. If the district needs legal counsel, they go to the Georgia State Nurses Association, who does have legal counsel. But it's never been necessary for the 5th District to ever seek legal counsel. Whatever is legal business in the district would certainly be the responsibility of the state association, since it is the mother organization. Mr. Jackson served as parliamentarian. He met with us on several occasions when the registry was set up with the Practical Nurse Association, which did require some legal work at that time, because they were adding in the Practical Nurse Bureau on this side and the professional registry on this side, which necessitated a city license for the professional registry to carry on the business of the nurses' professional registry. Therefore, we have to pay a city license for the practical nurse, but we do not have to pay it on the professional nurses' registry. So that was the only real piece of law work that he did for us. And he, of course, would interpret the bylaws for us as a parliamentarian. But that's been the only piece of business that he ever carried in the district that was anyway like in regards to legal work. With setting up the registry. Then that brought out the point that Mr. McClellan was employed as parliamentarian to succeed Mr. Jackson in the I think in the minutes that you stated, and you told me that the letter was written, and Mr. McClellan also stated that the letter was written to him from the 5th District as legal counsel. And the legal counsel, of course, would take care of legal work, and the parliamentarian would take care of parliamentarian work.
It seems we just sort of a victim of something that started, and we just sort of stayed in a pattern without thinking.
We don't need a legal counsel. We do need a parliamentarian in the district, and I believe it would certainly help us over many a pitfall to have
He agrees that he will be a parliamentarian, and I think he's had enough of the bylaws.
He has not ruled us right on the bylaws. He has not ruled us correctly on the bylaws.
Well, he has had the book.
He's had the book, but he surely hasn't studied it.
And,
because there's a lot of errors in his, certainly in his opinions to the president have been certainly not according to our bylaws, because every procedure for bylaws is written in the bylaw book. And if we had followed our bylaws in carrying out the responsibility of the bylaws, it's in the bylaw book, and we do not need legal counsel to take it.
But don't you think that probably a lot of our confusion has been brought about by the fact, too, that the state parliamentarian has given confusing information on things she's ruled on?
She has not given it.
She sure has, don't
She has not.
I know she has.
No, she hasn't.
But again, getting back to the motion, this is not
Yeah, this is our name, really.
I mean, we already just, we're talking about voting. It's right until September. By September, we would have to have all this discussion about whether we reappoint him or not.
I move the question.
Question's been called. You want the motion read again? I move that Mr. McClellan be retained as parliamentarian for the remainder of his term for 5th District USA. Moved by Jenkins, seconded by Ms. May.
He's already there.
Be retained instead of replaced.
Nobody else wanted to be replaced yet.
Well,
He's already employed.
Yes,
It's
we
only
got
been
one
voted
more.
on.
Yes.
To the people.
Those in favor, please raise your hand.
Vote on that.
Opposed? 6 opposed. 8 for.
Madam Chairman.
That was 6, no.
I just wanted to say that there was no need in having this motion at all. He was already hired for the year.
Well, but this lady here seems to think that, let's see, that you immediately appoint a registered parliamentarian to attend all meetings of 5th District yesterday, and also all meetings of 5th District. So, and if there's any question about the parliamentarian, his ability. We don't have to appoint, she's just one member in this thing. Well, no, you have to answer.
She also has sent another one today to the secretary to read.
Before we get away from this parliamentarian, may I make a motion?
Yes.
I move that we do have, for the September meeting, a parliamentarian for the annual meeting. Since Mr. McClellan is
Registered
he isn't. I mean, but you don't. Didn't have the state one there. You make like this one have the state one.
This is a plea for a parliamentarian from the same person. Do you want this read?
No.
She signed it, asking it to be read, and also wanted it published in the Leader.
Miss, I move that this be filed for information, because if she had, this information should have been sent to the president in time for her to review it before the meeting.
She she only got it completed today.
It doesn't have to be read. She should have gotten it there earlier, so the president could have.
Madam President, I think it really that we are getting away from the feelings of the members of the association. This association doesn't just belong to a few of us. I think it belongs to all of us. And I think we are getting away from the feeling that we all need the unity and we don't need this dissension in the groups. If we've got one member in this organization who is disgruntled, she's worth more to get her goodwill of the organization than it is to go out here and get 6 who will come in here and be just members. This person is interested in the organization or she wouldn't have written this. I don't know what it is. But I do believe that we ought to pay more attention to these people. If it is a criticism, maybe it is a criticism that we need. Criticism helps us sometimes. And I do feel that we are pushing things aside too lightly with our members and that we are creating ill will amongst the members of the association. And I am not mad with anybody. I want the things really treated in proper respect.
Well, I feel if she's gone to this much trouble that we ought to hear what she has to say.
I'd like to say something in regard to what Elizabeth says too. And I have a high regard for Miss Dixon and her opinions. But in a couple of meetings that we have been to in this building, some nurses have made it very clear, and I heard this statement said, and some other nurses heard it said too. And the nurses that said it says, I hate public health nurses. Now, as long as we have that type of feeling in this organization, then you may rest assured that there will never be any peace and harmony. I do not hate any group of nurses. We cannot do without any group of nurses.
That's right.
One is just as important in giving patient care as the other. And if people are going to carry their emotions on their sleeves all the time and work for disharmony, I don't see how we will ever make a go. I too say that running out and getting people just to be joiners is no good. And some of the people that should be in here working are staying out because there's so much bickering and carrying on in these meetings, and I think it's time it was
The
stopped.
bickering has just started here just recently, and we have had meetings that certainly in the district. I don't know when we've had as much upheaval as we've had here in the district.
We have, yes, I have known them to fight, and I knew when
Ms. Mace, we had the back in the
Bishop.
early 40s, when I first came into this district in the early 40s. Yes, I went to meetings. That was a disgrace.
You asked Miss Bishop
It
why
was
she doesn't
disgraceful,
come to
but
Fifth
we
District,
have
why
really
she doesn't. You asked Miss Bishop.
And it's not going
It's going to be the last one,
way
no.
to put it that way.
I was going to say the same thing. But we haven't had so
I
much.
have seen them so angry on the floor that I thought there was going to be hair pulling among the women.
Well, I'm going to tell you another thing.
And Miss Wells has been to those meetings, and we deal with personalities before we deal with issues.
But that was back in the early 40s. No, it's not just today. But we have gone through a year.
Time that we get I agree on that, and I certainly do agree.
Yes,
I do too.
But it's
It's bad.
this is not the first
Oh,
time.
no,
It's not going to be the last unless we change and look at things just a little bit different.
Well,
The tape was, this is the executive secretary, the tape was changed at this time, and Miss Bradley's letter was read by the secretary, Ms. Alford.
the proposed changes in the bylaws was again presented to the members assembled to have action taken upon them. Official notice, parentheses, stated in the March meeting. The proposition was at that time null and void. The action was illegal, and therefore when the meeting adjourned, it was still null and void. On April the 29th, the members of the 5th District GSNA convened in response to a notice published in the April meter for a special meeting. The notice was signed by the president of 5th District GSNA.
The occasion offers an excellent forum for discussing business and other points of interest to the members, but it was not in order to vote upon amendments to the bylaws of the 5th District at this meeting, since it was a special meeting. Bylaws in the 5th District may be amended only at regular and annual meetings. Very soon, the floor became an arena for the third bout with the E.L. Sayers proposed changes in the bylaws, which appeared in the null and void investiture, which it had acquired on January the 14th. It departed as it arrived, still wearing its null and void cloak. After rising first on 3 different occasions, I was finally permitted to be the last speaker on the 3rd round. I was thankful for this opportunity to speak. I rose and said, Madam Chairman, I wish to read from Robert's Rules of Order, revised, page 156, number 36, referring to reconsideration. Beginning with line 6, under 36, I read, it can be made only on the day of the vote to be reconsidered was taken. And on to the period on line 11, thinking that I was extending a courtesy to the chair and the members by reading the point of order from Robert's Rules of Order revised and leaving the chair to present the situation to the members. I took my seat without making a motion to reject reconsideration of proposed changes on the bylaws, because this status at that time was not legal, only to learn that the chair had completely ignored my call of attention to a point of order. The illegal question was presented for action to be taken upon it. Reference to democracy and democratic functioning was made by 2 speakers. My understanding is, and has always been, that the Georgia State Nurses Association was founded upon democratic principles, and that the 5th District, as a constituent of the state organization, is in conformity with it as regards to democracy. Recently, the bylaws of the 5th District on 3 occasions, to my knowledge, have been disregarded and votes taken on matters that were out of order. This is an unfortunate state of affairs for the 5th District GSNA. If such inattention to observing the bylaws is permitted to continue, we may find ourselves as an organization degenerating into a mass of people under tyrannical rule. I stand for democratic observance of bylaws in the 5th District GSNA, and I request, in conformance with Article 10, Section 15 of the 5th District GSNA bylaws, that a parliamentarian be provided to be present at all meetings of the 5th District GSNA, and also at all meetings of its Executive Board. Neil Bradley, RN, 5th District GSNA.
I thought there were 2 things.
Well, this was her. You read the other one.
I read the letter that was written to the
I
body.
have 2 other things here concerning parliamentarians that a lot of people understand. One is the attorney out here, Pauline Cousins. This is another member of GSNA. You want those read now?
Miss Money, we have heard from you.
I'll read the district report first. This is for April 1965. Brought forward to March, $4,928.87. Receipts, membership dues, $4,257.75. American Journal of Nursing subscriptions, $33. Total, $4,290.75. March check, there's a check redeposited $32.50, making, and with the 4,000 that was brought forward and the 4,209.75
32 less $9,252.12. Disbursements, rent, $63.50. Salary, $384.37. Phone, $51.77. Postmaster, $100. Supplies, $36.36. American Journal Nursing subscription, $35. Internal Revenue, $240.06. GSNA, $3,172.50. Miscellaneous, $61. Total, $4,144.56. Bounce, $5,107.56. 2 checks returned, insufficient funds, $65. Clearing bank, $5,042.56. Checks out, $720.99. Agrees with bank statement, $5,763.55. There's 3 checks out, 3927 checks, $20. 3929, $686.25. 3930, $14.74. Total, $720.99. Obligations to the government, the withholding tax, $47.40. Social Security, $32.62. Total, $80.02. State of Georgia withholding, $7.68. Total, $87.70. I move that this report be accepted. Moving second, the treasurer's report be accepted. Is there discussion, question?
Madam Chairman, may I just ask for information because I don't understand it. What is it we pay to the Internal Revenue?
That's what you take out of my check, my salary check.
Social
It's taken out of withholding tax and Social Security. And we pay it quarterly. And the big checks you see outstanding usually are for membership, and $600 one is for membership to the GSNA on that, in case you want to know.
Is there other questions?
There's a new ruling on the Georgia state withholding. You can't send it in now until it, I believe, totals $18. Anyhow, the quarterly reports used to have to go in at $5.76, but now you have to wait a while.
Are you ready to vote? Question. Those in favor say aye, please.
Aye.
Contrary, no. Thank you. Motion carries. D, Nurses Professional Register Financial Report. This was for March 1965. Previous bank balance, $6,699.10. Membership dues and bill heads, $5,643.10. Total, $12,342.20. Disbursement, salary, $1,348.30. The fund insurance company, $10. Young, Garber and Company, auditors, $260. Employment, Social Security Agency, $10.96. State of Georgia Income Tax Unit, $19.46. District Director, Internal Revenue Unit, $347.28.
rent, Henry Brady Hotel, $125. Southern Bell Telephone and Telegraph Company, $49.25. Total, $2,170.25. Disbursement this month, $2,170.25. Cleared outstanding checks, $1,138.25. Total, $3,308.50. Balance in the bank, $12,342.20. Disbursement, $3,308.50. Total, this is the total balance in the bank, $9,033.70. The outstanding checks, $716.31. The balance, bank balance of March the 31st, 65, was $9,000. Book here. Well, let me have it. The reason why I can't read it, this Cooper brought it over. That's the March from after the last one. And my hand was full of weed, and I put the film right on that spot, which I'm very sorry. I'll go back. Bank balance of March the 31st, 65, $9,750.01. I could read that, but I was afraid it was wrong. Minus outstanding checks, $716.31. Agrees with the checkbook, and this is the balance in the bank, $9,033.70. I move that this report be accepted. Is there discussion? Well, it's a big discussion, but let me, after the last report I read in the March meeting at the here at St. Joseph, a private duty nurse from St. Joseph called me the next night and was questioning me, why did the official register, it was the auditor's report I read that they were questioning, why did the official register send so many telegrams, which to me was a stupid thing. All of our telephone bills come telephone and telegraph, and that's the way they had listed it, and that's the way I read it. I read what's on the paper. That amount of money was, and that's what I told this person. I said, now you go back and tell the people that were present when this discussion was there at St. Joseph, tell them, look at their own telephone bill and see how it's listed. And they would go long distance calls. If they were, people paid for them.
Well, that's mainly the advertising in the yellow pages. That's included in that. What there is this one. Those in favor of accepting the report, please say aye.
I didn't know whether any of you people were present at that discussion, but I wanted to make it clear. Let's look at your own telephone bill and know how they go. Thank you, Ms. Hines. We have a report from the special study. Well, I'm going to make it very brief and give you our membership up to date. We have in the CESR section 7, EAT 101, administrators 204 plus 1, general duty 144 plus 2 associates, occupational health 41, public health 118, private duty 409 plus 2, making a total of 1,024 with 5 associates. That is as of May the 1st. Now, since that time, we have received 10 renewals. We don't send them in weekly now, from now on, and that gives us a total of 1,034 plus 5, and the sections will get that check based on that, the 10 cents per member plus the 15. We've been busy in the office, many activities carried on, the bookkeeping is up to date. We're working on our programs recently.
Membership's up over last year.
No, we just one more than we were this time last year. I'm glad you brought that out. I looked to see because we were 200 ahead earlier. We got a good start. But we had 1,033 last year on May 5th. So we still need some help. 1,034 plus 5. I have 10 to send in that came in this week.
Yeah, optimistic you're one ahead.
One ahead. Yeah, maybe that's that one disgruntled.
Last year, y'all had to finance other than your school. You gave membership and credentials. Nominations, Ms. Mahan.
I haven't received any. You will. We have gotten them from all sections and one alumni. And they will be tabulated, you know, of course, through tonight's meeting would be the last time anyone could make a suggestion to be turned over to you. Okay. We send them out, get that permission, so it'll be sent to you.
Now, set us straight on, this has to be approved by the board before it goes to the meeting.
Well, that's one point that I wanted y'all to decide about that, since we don't have a July meeting. Do you want to send out a referendum vote after you've had your nomination and have the ballot approved by referendum and printed in the meter? You're supposed to have it in September, you see, in time for you to vote on September the 9th. You don't have a board meeting until September the 7th. So we have had an order there that we put the biographical sketches and the pictures. Well, we didn't get many pictures, and we better cut down on the finances for the pictures, but we would like to have the biographical sketches on them, and with your permission, whatever you'd like to do. We'll have to have it by August the 15th to get out in time.
And in order to put it in the meter, we will have to have the referendum vote.
The board is to approve the proposed ballot, as I understand it. According to you, maybe it's supposed to.
But excuse me.
Mr. President, I want to call attention to the Committee on Nominations. It's the only committee that cannot be interfered with any other person, not even the chair, or not even the president of the association can serve with the Committee on Nominations. That's the only committee that is a committee which is in its own self.
May I ask a question? If member is proposed by a group as a nominee, and she happens to be on that committee. She can't serve. Well, that's what I wanted to know.
No, but
all of these candidates, these nominees should be going to the chairman of nominations. She's the only person should have this material.
She will be sent back.
And yes, but it should be going to under in postage under mail.
It will.
Not from you, but you've already worked on it. You're working on it for biographical sketches now before the Committee on Nominations gets it, which is not the proper
Supposed to come to her
Committee on
first.
Nominations. It should go to the Committee on Nominations. She may not, this committee may not accept all of the, may not need all the names of these people, and some of them may decline between now and September. But these names go to her.
They will.
Then it's the committee, I know. But my point is that that should not be in your hands, just like the nominations that are sent to the Georgia State Nurses Association. I don't think.
Now, why is this written?
That's under nominations. Under Robert
Robert's
rules will cover that.
There was something else that we were looking for.
Committee on Nominations about anybody, and these nominations go to the chairman of the Committee on Nominations. Then, when these people, this committee works on them, and they request that
Well, I will have to be back on a certain date. If you look on the manual on that, we have deadlines on that.
That's right, that the Committee on Nominations, the person who determines this.
We will have to, on the state, have it in by July the 1st.
Well, the chairman's committee on nominations, is not supposed to have her name on the ballot, is that right?
That's right.
What I have heard, but I couldn't find that either. I know it's in the A&A.
Would you put in page 263, 289.
Now, look at those lists, because we looked at all of them, and doesn't spell that out on the
Treatment of nominations, and they've got
I know in the A&A, it says that I have the A&A, says that if the name of a member of the Committee on Nominations is submitted as a suggested candidate for the ballot of this association with the permission of that member, said member shall resign from the committee.
That's right.
And, but I
with
couldn't find that other. Yeah. Even though the person gives consent for her name to be on the ballot, she's got to resign from the Committee on Nominations. That's right. Well, I'll tell you what, back in my young days, she can decline again, decide to decline and stay on. She can decline either one she wants to, either on the committee or the ballot, but she can't be on both. This is what is legal. Quote legal. But this other, while we are looking at, suppose we go on to the program committee on program. Well, apply for David 12 and 6:30 on dedication service of all things Episcopal Church as their supply response during the stating the great number of persons in attendance in the award program is 8 p.m. for Academy Center. Cover their fine program and work on behalf of the career to assist in this activity. And all of you. Thank you. Mrs. White, you have a report? No, I do not have a report because we have not met. But I would like to request from the executive secretary to see if it would be possible for us to get the information, these 3 pieces that she sent me for each member of the registry committee so that we would know what the physical plant duties are and what we're supposed to do with it. In other words, I think each member of the registry committee should have this information to study. You have the bylaws and then you have the manual and what other did I on committee the register manual or the bylaws of 5th District and the policies and procedures of the Nurses Professional Registry. That's 5th District. Oh, let's see now, I got the bylaws, the manual, and what was the other one? Was that the committee? The register manual of the Georgia State Nurses Association. Yes. I'll have to get some of those and we'll see. Minimum was found. Minimum was found. And we will meet on Tuesday. Preceding private duty service. So we're trying to do
when you act on this in your section, it doesn't tell you how from where to go from there. But not from when I did them on, but there's nothing because see, when we met at our last meeting, we had, and I had to say, I don't know why I did, but it got a report from the ACC. We had a meeting last Wednesday with 49 present, and the topic was selection of learning experiences for students. The college is very well attended, and we've been pleased with the whole year's attendance. At our last meeting out at the Deb Convalescent Center, and it was just real nice. The lady was just very gracious to us, and she took us on tour, and then we did not have a program that night because that was the night the care of the stroke, first 24-hour care of the stroke patient at the academy, so we disbanded in time for the people who wanted to go to band. We've had excellent attendance this past year. How many? We had 49 at our last meeting. 49, yes, learning experience. The role that Clinton was talking about. Did you have 49 children? Well, the 21st. I mean, 12. You plan to have a meeting on the 19th too, don't you? I've got to count. Why is you all done that operating room? You still have a conference room, a section of the facility from Syracuse? No, we haven't had that since also have class. Well, maybe that first part. Well, I know some operating room nurses you probably know who they are from outside. But I'm just wondering. At our April meeting, Dr. Minor, the cardiologist, showed slides and brought the program to us. And then the June one, we are going to meet at the Georgia Training School for Girls and have supper there and get a tour of the facilities out there for the June meeting. No recommendations. About it's been our average, I think it was 12. I have no idea. It was well attended, but I really have no idea. I would say there were probably 60 or 70, but I really don't know how many. That was on April 8th, I believe. We have not had a meeting because they took all day, and I would like to know who had the authority to take a credit date that's on the calendar. That date is settled by the attorney. And we thought this was something that you would want. It wasn't what we asked for. And I don't think the attorney even had the right to take a date that was already printed on the calendar. Well, so we are having a postponed meeting this Thursday, and we are having a two-session since on the afternoon nurses had asked for a morning session that they couldn't come, and it will be held at the Atlanta Red Cross chapter at 10 a.m. Thursday morning, and we'll continue with the afternoon meeting as a 4 o'clock meeting at Crawford Long Nurses Home. May 13th. We up here, we could add to a workshop as the general duty. And this phone, you got to message that they want to do something with this. I think it's all with the view of the house and uniform. There's no water. This no water is the chairman of the state section, General Duty. They're having well, this is the workshop is May 27th, and is that right?
that workshop. She's going to arrive here May the 27th. Yeah, so she's coming May 27th, workshop May 28th. General duty. The general duty section of the GSNA, Ms. Stanback from A&A is coming, and the topic, I believe, is function standards and function standards if the medical academy wants all the meetings. Was that a Friday? Thursday or Friday? Pilgrims, they should read what time is that? All day. Yes, Friday, I know Memorial Day somewhere along that weekend. Registration 9 o'clock, and Miss Harriet S. Stanback will be the resource person from A&A. Function standards and qualifications is the name of the workshop. To be held May 28th for all professional registrations. Work on this, try to get this going, and Madam Person, is there a registration fee for this? No, okay, just in case somebody else. Thank you. Yeah, it's cool. All nurses. There you go. I may have that thing on. You can make her work. I'll remind you that there will be no July meeting, either board or district.
This is from attorney Pauline E. Cousins to the Executive Board of 5th District GSNA. This is to certify that I have carefully examined the report of the parliamentarian of the Georgia State Nurses Association, Esther Watts, regarding the action taken at the March 11, 1965 meeting, that I have studied the law of Georgia on the question of the binding effect of bylaws on an organization, and I have studied Robert's Rules of Order revised. In my opinion, the action taken at the March 11, 1965 meeting regarding amending the bylaws was null and void as being contrary to law, contrary to provision of the bylaws, and therefore of no effect. In my opinion, the action taken at the April 29, 1965 meeting was also null and void as being contrary to law, contrary to the provision of the bylaws, and therefore of no effect. The bylaws of an association are the governing authority and are binding on all members. In any action taken which is in conflict with the bylaws, even if unanimous, is null and void. Robert's Rules of Order revised, Section 47. I am in complete agreement with the statement set out in the report of Esther Watts. Respectfully submitted, Pauline E. Cousins. This one was from one of the members, Ms. to the Executive Board of 5th District GSNA. Dear Mrs. Alford, I request that at the next meeting of the Executive Board, a parliamentarian be appointed as provided for in Article 10, Section 15 of the bylaws of 5th District GSNA, and that the parliamentarian be present at all future called, regular, and annual meetings. Sincerely, Mrs. Ernestine S. Phillips, 5th District GSNA. Well, I think it's an insult to our president for those letters to go to the secretary instead of the president. Well, who is Miss Cousins? Is she a member? Who agrees with me? That was the way I feel. Well, if she's so interested in this organization, why should she come to the meeting? Well, she can't come to the board meeting. She can come to the district. One of our members, Miss Phillips. I'm talking about Miss Cousins. Is she a member? No, this is... I don't think she has any right to advise us. We had... Ms. Garland should like her to tell her which we will her advice, we will ask her for. Well, I think that is Mr. I think we've taken care of the subject of the parliamentarian for this year. I move to adjourn. Well, I was just asked how we did for information. I was asked for more information on there was something that they were discussing. Okay, I appreciate your motion to adjourn. Would like to know what to do about our referendum vote. I was wrong. I just heard you say that was all on our agenda. Well, public reference. Well, nomination. I'll vote comfortable with your the ballot before she gets crazy. Let me find this. There's so many things that's in here reference. I know. Let me find it now. Well, I believe we had a parliamentarian now that can enlighten us on this. Well, according to the manual, that you do approve the ballot. So if it's all right with you, after the committee meets their report, may we send it to you for referendum vote? And then go ahead and act accordingly. We need it by August the 15th. We will not have a board meeting by that time. You'll have a board meeting on September the 7th. And the meeting should be out by that time. I guess you could call a meeting. Call a meeting, couldn't you? What are the duties of the committee on call meetings for other things? Well, I thought that Golden used was to prepare, to meet and take the names that are submitted, and then if anyone nominated from the floor can be added to the ballot at the annual meeting. Isn't that correct? First of the motion.